the title is sort of the prospectus for 7 Tesla MRI, and MRI came into clinical use in the 1980s and has made tremendous advances over the years. In the 80s, already sort of the standard field strength was set at 1.5 Tesla. That's the strength of the magnet. And in the last decade, we've seen the emergence in the clinic, at least, of 3 Tesla machines. And now we're talking about maybe even moving up to an even higher field strength, 7 Tesla. And at this point, I should say that all of these machines are only in the research use right now. There is no MR system certified for clinical use above 3 Tesla at the current time. And so one of the questions you might have is, why do we want to go to these higher magnetic field strengths? And the primary reason, the easiest reason, is that it increases the signal out of the body, and we can use that signal in multiple ways. But it also goes along with a number of technical challenges in terms of imaging. And I'm not going to go into those hurdles today because, at least in the brain, they've been largely overcome. But they are existent, and that is one of the largest areas of research going on at these higher fields. And another challenge for these machines is also economic. If you want to purchase one of these machines from General Electric or Philips or Siemens, they'll probably ask on the order of about €1 million per Tesla for the machine. So if this were to make it into the clinic, then obviously the reimbursement would have to be adjusted compared to normal MR machines. So maybe I'll just also mention, as was already said, that I did work in Essen up until about 6 months ago at the Erwin L. Hahn Institute. So many of the examples I'll be showing you are from there, as well as from the German Cancer Research Center. And this first image on here is actually maybe a good motivation for looking at 7 Tesla. This is an image of oxygen in the brain acquired with MR. So not the functional MRI that you may be aware of, but a direct depiction of O17 isotope. And in this case, you can see that the tumor has converted to anaerobic metabolism, and therefore the oxygen consumption has gone down. And you can go through a list of sort of things that get better at high field to actually motivate what you could look at in terms of clinical perspective. And one of the first things is, of course, the higher signal allows us to go to higher spatial resolution, and I think everybody would agree higher resolution images are potentially better. But there are also a number of contrasts, tissue contrasts, that are improved. Bold and SWI are related to magnetic susceptibility, and your sensitivity to that improves. And time of flight contrast, which is used for depicting the arteries, also improves. Then there's sort of a whole new world that's opened up due to the advantages of the higher field in terms of detecting hydrogen, which is not in the free water pool. Normally in MRI, what we're looking at is the free water and the fat in the body. And the hydrogen that is in proteins or metabolites or whatever is not really playing a role. But you can use techniques like spectroscopy and CES to look at those. And then finally, even going beyond hydrogen to other nuclei such as sodium, potassium, oxygen, as I showed before. So here's just a quick example of higher resolution, 1.5 Tesla compared to 7 Tesla. And you can see in this tumor that there are some additional details apparent. And of course, this does lead to an improvement in terms of detecting certain pathologies, especially small, fine pathologies. But a lot of the improvements that have been observed at 7 Tesla are related to these improved tissue contrasts. This is an example of susceptibility-weighted imaging, looking at the venous vasculature. And these two acquisitions were held to the same imaging time to allow comparison. And you can see just a huge improvement in the vascular detail that you can get at 7 Tesla. And this can be applied to detecting things such as the pathologies in the veins, but also any kind of bleeding and blood products. In this case, looking at brain metastases, so bronchial carcinoma, and it was possible to identify in the series of patients more metastases at the higher field strength than at the lower field strength. On the right is an example of a contrast-enhanced image at 3T, and on the left a 7T image with susceptibility-weighted contrast, and you can see just the amazing amount of detail that you get inside the necrotic region of the tumor. And we have a project going on that looks at this internal structure and tries to then predict using computer tools how the further tumor progression will be, sort of in what direction the tumor will progress. This is another tumor example where you can see the fine vessels within the tumor bed, much better than at the lower field strength. And that might be helpful, for instance, in staging of the tumor, but also potentially for monitoring tumor or therapy response. And this is an example of just such a study where this is from Vienna, given to me by Siegfried Tratnich. And what they did is they used SWI over time. So this is at the beginning of anti-angiogenic therapy, after 2 weeks and after 4 weeks. And basically, it appears as if the tumor is further progressing, that there's an increase in the vascularity in the tumor. So a sign that the therapy is not working, and that was verified by the clinical progression of this patient. And if we look then to the arterial side, again, the time of flight contrast it profits also enormously at higher field strengths. This depiction here. And in this lower grade tumor, you can see that some of the major blood vessels are sort of displaced, but there's no sign of neovascularization yet. Whereas we go to a higher tumor, the glioblastoma, then you can see the very fine neovascularization inside the tumor bed, which is generally not depictable with other techniques. And this is, again, something that might be useful either for tumor grading or for monitoring therapy response. So what I've shown up to this point are basically extensions of things that are used in clinical routine every day, just at the new field strength. But there are some emerging applications that work at the higher field strength better than at lower field strengths that open up new windows into the body and into pathology. And one of those is looking at protons that aren't in the free water pool. So normally we're looking at the water, but let's say we want to look at the amide protons in proteins. The problem is the signal from these protons is quite small compared to the massive amount of water in the body. And so what is done in chemical exchange saturation transfer is you play a trick and you transfer the signal from this small peak onto this large peak. And that is shown in this video. Basically, you apply an RF pulse at the resonance frequency of these protons in the amide modules, and they are in chemical exchange with, as shown here, with the free water pool. And therefore, you will get indirectly a saturation of the water signal. So if you then vary this off resonance frequency across a bandwidth both below and above the water resonance, you will get a spectrum of signals, and based on this signal, you can start to say things about protein concentrations, pH, and other things. And this is an example. This was an early study done with 7 Tesla assessed imaging, shown here in the middle. And the first thing that's of interest is that the contrast in the image that's revealed was not really, could not be really directly correlated to the T1 and T2 images that were conventionally acquired, in this case at 3 Tesla. So it indicates that we're getting some sort of new information. The question is, what is this information revealing? And one of the problems with the CEST technique is that this CEST signal depends on many factors, as I just mentioned, such as the pH or the protein concentration. It's also dependent on the protein folding state. And just recently, a group in Heidelberg has been able to show that in vitro, you can really show the exact folding state of the proteins using CEST imaging. And so now the question is, can we extend that to in vivo imaging? And this is unknown if this, but as the title of the talk indicated, it's really about the potential right now. If these hotspots are related, for instance, to enhanced malignity, then they might be useful, for instance, for guiding a biopsy in order to determine the exact stage of the tumor. And finally, going beyond hydrogen to other isotopes, these isotopes have been investigated actually since the beginning of MR. They are used in NMR spectroscopy for chemical analysis, of course, routinely. Then the problem is that the signal that's available is very weak. If you compare this to the in vivo signal from hydrogen at a level of 1, the signal from sodium or from potassium is from tens of thousands to millions lower. Potentially you can measure that, but you would need to invest a lot of time. But this comparison between field strengths shows you that now moving from 1.5 T to 3 T now, and up to 7 T, you're getting into a region where within a clinically reasonable time, you can get decent image resolution, in this case 4 by 4 by 4 millimeters. So this is also an area of active research at the current time. And you can see these are conventional proton imaging at 3 Tesla and the sodium images at 7 Tesla. And again, what's interesting is that the contrasts that we can get in the images are not matching up directly to what we've had up to this point. So this is an indicator that we are getting new information. The question is exactly how can we use this information to improve the diagnosis? And this is an example where not only sodium was acquired, but also the chloride ions. And actually, while there's 2 different techniques shown here in each case, this first technique is weighted towards the total sodium concentration. This technique is weighted more to the intracellular concentration. And so you see that there's a difference, but what's also apparent here is there's a difference in the sodium and the chloride concentrations in the way they move with the pathology. One may go up, whereas the other one's going down. That's maybe not what you would expect at first, because you might expect sodium and chloride to be balanced within the body. And now, as I mentioned, and as you've seen, what I've been showing up to this point was all out of the brain. And I mentioned at the very beginning of the talk that there are a number of technical challenges in how we get images out of the body at 7 Tesla. It's not easy. And you've seen that in the brain that works quite well now. But if you do conventional imaging in the body, These are cross-sections through the abdomen and through the pelvis. You get these signal dropouts in various areas, which basically make the images useless for clinical diagnosis. However, there's been a tremendous amount of work done in the past few years by various groups, and it is now possible to get very nice images from larger cross-sections within the body, although it's still not a solved problem, still many issues to be addressed. And this is generally done by applying new excitation technology, which basically involves dividing up your excitation antenna into multiple elements. This is well known on the reception side in MR, where we have these surface coils with many elements. Now we're doing the same thing on the transmit side. And the first organs of interest, so to say, within the torso are also organs which have a limited cross-section, so similar to the brain, where the techniques that we can use to improve the excitation work better. And here's an example from Vienna, from the breast again, and you can see that at 7 Tesla, much higher spatial resolution achieved, in this case 0.7 millimeters isotropic, and this allowed them to, in this series of patients, improve the diagnostic accuracy by a small percentage. And again, another organ that is of interest because it has a small cross-section is the prostate, and this is work done by the group from Nijmegen, Tom Schienen, in Essen, and we were able to get very nice depiction of the prostate, and they are now working on a multiparametric protocol, including spectroscopy, both with hydrogen and with phosphorus, and looking at what this information at 7 Tesla can bring in terms of improving the characterization of the cancer. And just as a final imaging example, just to show you that, at least from my perspective, the message should be that there are a lot of challenges involved at 7 Tesla, but I think we will solve those. That's why there are a lot of engineers and physicists around the world working in MRs, because there are always these interesting challenges, but they always get solved. And in this case, you can see the depiction of the runoff vessels in the legs using no contrast agent at 7T versus a contrast-enhanced exam at 1.5T, and very nice depiction, for instance, of the small collateral vessels. So just to summarize, if you look at a higher field strength on paper, you can come up from a sort of physics perspective a number of reasons or motivations for why the higher field strength would be of advantage. The first one everybody is going to mention is the higher signal-to-noise ratio from the body, which allows us to do higher spatial resolution. But also other things such as spectral information, because the individual resonances of the metabolites move apart as you go up in field strength, in addition to the increased sensitivity. So there is quite a large potential in terms of improving staging or biopsy targeting therapy response in oncology, but also in a wide spectrum of other diseases. Right now, I would say there are about 45 of these systems installed worldwide, so it's still a very small community. But still, there have been a lot of methodological improvements introduced in the past few years, which indicate we'll be able to really apply 7 Tesla in the entire body. And it's already clear, and 7 Tesla has already contributed to understanding pathophysiological mechanisms in various diseases. So basically, if you take a group of patients with the same disease and you perform a study, this is a useful tool. But the question, I guess, motivated by the title of the talk is, can 7 Tesla make it into clinical routine? In that case, you're trying to apply the technology to an individual person. And in that case, the evaluation of 7 Tesla is still ongoing. And as I mentioned at the beginning, there's still no regulatory approval of 7 Tesla as a medical device. But my personal prediction is that it will make its way into the clinic. There was some concern recently because the only manufacturer of 7 Tesla magnets worldwide decided to withdraw from the business. However, at least 2 of the major vendors have now announced plans, alternative plans, to produce magnets or produce them in conjunction with partners. So the field is still moving ahead, and I think it will be just a matter of time. Yeah, I'd like to thank the group in Heidelberg, the group in Essen, and our funders, and thank you for your attention.